With the first PVC ablation of the year 2023, we had a Palestinian doctor, a female doctor, 35 years old, with frequent PVCs on the surface ECG and non-sustained VT on her Holter. Her echo was normal. She used many medication. Then she stopped her medication on a few days ago, which was bisoprolol. We localized it, and we'll show you on the screen that it was from the right ventricular outflow tract looking posterior. Salah, you made the localization. To us.
The localization, okay. Okay, we can appreciate the localization from the precordial leads. We can see the transition almost at V3, which carries a 50% chance in the RVUT and the LVUT. The axis in the inferior lead is inferior axis. A slight notch here in the inferior leads, and a positive notched R wave at lead 1.
Lead 1,
this is limb lead 1. Okay. Yeah. So we started the mapping of the RVUT first before doing a femoral artery puncture, which we achieved a very early signal we will show now. اوكي هنشوف السايت اوف ابليشن. لا ما خلصت اللوكاليزيشن سريع We can measure the we are earlier than the QRS complex pure by about 32 milliseconds.
So you started mapping in the right ventricular outflow tract, but you were ready to map the left ventricular outflow tract
for sure,
for the possibility of a left ventricular origin.
Yeah.
Because this is a posterior location.
Yes.
So posterior
RVUT is
looking at the coronary.
mainly to the right coronary cusp, right coronary cusp, okay, and a part of the left coronary cusp.
So you started placing your cheese,
yes,
8 French, and you used هنبص بقى على الفلورو هنا.
Okay.
Yeah. This is stay there في the successful ablation site.
Okay. دكتور جون هي Okay.
Salah, you placed a decapolar catheter in the CS, yes, and then the Carto catheter with 8 French sheaths in the femoral vein. You did not do the femoral arch puncture until you make sure that the right side, in order to minimize the amount of anticoagulation and femoral arch. Yeah, you started placing the catheter and you were mapping
the posterior part of RVUT. Yeah. We achieved a very early signal at the posterior part of RVUT, more septal part of RVUT, at a higher, just subpulmonic. It's subpulmonic. Because it's higher, the AVL was completely negative. Yes. Okay.
Then Alfie went after you to where were you looking for, Alfie?
Actually, I was trying to reach the posterior wall of the RVUT, but the best thing in our team that we change hands of the operator, and when Prof. John came, he just make anti-clockwise of the catheter, and it went posteriorly and get the best signal.
Okay. So and John, you decided to go to the right side, not to the left side.
Yes.
Now here.
Yes. At first, you should make a good map, a complete map of RVUT. So if you think you did not reach some place, try by clockwise and anti-clockwise. So when I got anti-clockwise, rotation of the catheter, I hit the posterior wall, posterior wall septum, and then the PVCs suddenly inhibited and suppressed even by catheter manipulation. The last beat of the PVCs, I got early signal 32 milliseconds before the QRS complex, and then inhibited.
Yeah.
So Professor Dr. Mervat decided to ablate at such a point.
But before ablation, I wanted to make more sure by pacing. Pacing بقى كان 100% or 97%. We were using the Carto for PVC localization, and the Carto has this privilege of pattern match. ده النجاح. ان انت to have a pattern match اهو for the PVC. دي مش ال PVC. This is the pattern match, yes. We look at the number. If you get pattern match less than 97, we don't care. So pacing helped us when we reach هات ال site of pacing. Yeah, here. هات pacing. لا مش ال RV. Same site of ablation we paced in order to get almost 100% زي ما اتأكدنا من الكارتون. بعد كده حصل ايه يا جون؟
Professor Dr. Mervat decided to ablate at such points which is suppress the PVCs by using the cartoon. The cartoon is easily to tag this point. So Khalid tags such a point in order.
This is the light blue ball.
Yes.
العلامة دي.
Where we ablate at such point and PVCs did not recur even after isoprenaline infusion and bolus.
Okay, Salah, you told me that there was vasovagal reaction of the patient.
It seems that she has, after finishing puncture and starting to put the catheter, we saw the bradycardia and a pallor in her face. So actually we started, first I told her to cough, during cough, and she regained her blood pressure and heart rate. And we started, like 40, Tawfiq can show us the bradycardia at first. I want also highlight the signal on the CAR2 using a unipolar signal. He showed to us now the site of ablation on the CAR2, both at the map and
What is this view?
this is the LLO view and the REO view.
To the left?
Yes, we are almost as if we are in the left side.
The septum.
Yeah.
Dr. John says that he pushed the septum with the catheter as if he's going to the summit. LV summit. Also, we have to highlight that the signal, the unipolar signal on distal ablation catheter is QS, which means that we are at almost the site of origin of the PVCs, and it preceding the QRS complex by about how many?
Was the energy
50. What? 33.
And on cartoon 119 milliseconds.
that duration لكن الباور
We started 35 watt, and at the last 30 seconds it was 40 watt.
You were watching the impedance. What is the importance of watching the impedance?
Because of this, it should not exceed the 8, go down by 18 or 20, or higher at 20.
So you're watching the impedance
Avoiding
helps you to watch the tissue reaction.
Yes, and also to avoid.
It will pop out
And maybe
Yes. Right.
I want to say to Dr. John that I always afraid in this area to push the septum or even the free wall of the RVT.
That is not. It was not. If this is the free wall, we will be very more careful. Will not give that energy. So what is the complication? ربنا يحفظنا out of this
The complication, if you push the catheter strongly, it can easily perforate the RVT. So here is the miracle of contact catheter.
Contact force help
catheter.
to protect the patient.
Yes, definitely. I think with use of
مين وقع؟ طب ماشي.
في كان بيمسحوا دلوقتي.
طب ماشي. انا قلت في حاجه. لا المكن. خلي بالك ما حدش يحط شيء تاني هنا. Okay, Dr. John, we were talking about the complications. طبعا we are in this high septum. Is there any artery close to this site?
By ablating in the RVT proper, you are away from any epicardial coronary artery in the proper RVT. But if you ablate in the pulmonary artery, you are close to the left main coronary artery.
Left main, you have to be
So
very careful.
when you ablate to the RVT, you are away from the epicardial coronary.
طبعا there is, because you are in the septum, you have to be watching the catheter very carefully that it does not drop يعني تقع منك and the septum and you are يعني away from the his Yeah, you have to make it.
Dr. June, about the corresponding site in the left side in the LVUT of our site of ablation at the RVUT.
Corresponding.
The corresponding, I guess it is the commissure between the left coronary cusp and the right coronary cusp, or left coronary cusp alone. This is the corresponding site. You can easily now make a femoral artery puncture and good anatomical map of left coronary cusp and right coronary cusp and see where is close to the location. But I definitely will.
ECG before ablation here, we can take a look, yeah, Ali. Zoom on this, and this is why I said it is RVOT, because of the lead transition of the QRS of the PVC compared to her resting QRS. This is how we make it. But still, limb bleed 1 positive and AVL negative. It is high. It is from the posterior wall, and I think that was a very successful one. Now we reached the waiting period. Hey, وريني علي. The waiting period 30 minutes, and end of study. End of study.